Right. Well, welcome everybody. And thank you. Thank you for your patience through that technical kerfuffle. That was a very 2020 in 2021. Gosh, when are we ever going to escape? So welcome to Sac State. I am Mary Mcguire. I'm so pleased that you are all with us today. I do a number of things at the university, one of which is to shepherd the Center for Health Practice Policy and Research. And that our mission at the center, which we affectionately refer to as CHIPPER, is to foster health and social equity through interprofessional education and service and policy and research. That is the reason, it's really to advance that mission that we brought everybody together today. We really wanted to hear from a broad interprofessional group of people in the community and the state to look at issues of addiction. How do we reduce barriers? How do we reduce harm? Increase access and facilitate more creative treatments and treatment models. So I'm really excited about the discussions that we're going to have today, and I appreciate everybody joining us. This is a fantastic opportunity. I want to give a special shout out to the College of Education, and in particular, our planning team there. This would not have possibly happened without Doctors Beta Rivas, Anthony Rivas, and Carly Scarton. A special thank you actually to Beta Rivas. Not only is she a fantastic colleague and very competent, but she did the heavy lift so that all of us could come together today and make a difference for the state of California. So thank you, Dr. Rivas. I also, a very, very special thank you to our generous, very generous community sponsor, the Sierra Health Foundation, not only for supporting us in this program today, but for being such an outstanding champion for health equity in the state. I'd like to introduce you to the Senior Vice President for Partnerships and Programs at Sierra Health, Kai-Ying Hang. Kai-Ying?
Great. Thank you so much, Dr. Maguire. Good morning, everyone, and thank you so much for deciding to spend your day with us. As Dr. Maguire said, my name is Kai-Ying Hang, and I have the pleasure of serving as the Senior Vice President of Programs and Partnership for the Sierra Health Foundation and the Center Sierra Health Foundation, and we are thrilled to be a co-sponsor for today's symposium. It's hard to believe that when Drs. Rivas and Maguire first approached us and my colleague at the foundation almost 2 years ago, that here we are. We would be in the middle of a global pandemic, right? A pandemic that in the country has taken more than 450,000 in climbing deaths, and here in the state of California, 45,000 in growing deaths. And so, on top of understanding the implications and years of life lost due to substance use disorders and opioid, the pandemic reminds us of the need to be diligent about how we create a community of practice and colleagues together to really, understand what the potentials are as you all help us to serve the population across the continuum of care. And so, I'm just in this moment of reflection, and given the conversation we began pre-COVID with Mary and Vitas, I have to say I'm reminded, right, tragically reminded of the social isolation, the economic stress, and the increase in mental health, as well as substance use disorder. And some of you may have seen a recent JAMA article that really suggests that there has been a spike in terms of opioid overdose in 2020 due to all the things that we know are associated with COVID. And so if there is ever a time, Mary and Vitas, for us to bring this incredible community of professionals together, I would say now is that time. So thank you Thank you for staying with your vision, Vita. Thank you for your commitment, Mary, and to all of you at Sac State who is committed to building and strengthening that community practice. We are just so delighted to have you as a partner. I know that our task today is about bringing all of us together to support prevention, education, stigma reduction, treatment recovery, options, set of options. And we're thrilled to be engaged in a conversation. While I know that this may not be the first time that many of you have come together for this conversation, I am hopeful that after today's symposium, that this conversation, this community continues to build on the conversations that are taking place today. I am, some of my most favorite people are serving as panelists. Dr. Ryan Quist, Dr. MK, and so many others who I know day in and out are committed to this work. So I want to thank you all for your commitment as well. For us at Sierra Health Foundation and Center, we've been deeply engaged in this work for a very long time. But most recently, in the last 2 years, since we've launched our medication-assisted treatment access points program. In the last 2 years, we are looking with last year's grant making, in addition to this year, we are planning to make at least $88 million in terms of grant support across this continuum of care. And many of you have been engaged as partners in this effort. And we look forward to being able to partner with you as we continue to build a network of community, not just here in Sacramento, which I know is very much the focus today, but how do we extend the work that you are all engaged and involved in statewide and perhaps national. California is a leader in so many areas, and I would say that our ability to proactively respond to the opioid use disorder crisis is one where we will also have an opportunity to be a leader nationally. So in the spirit of Sierra Health Foundation and the work that we do, as some of you know, we center our work around communities that have been disproportionately impacted. So we bring to it an explicit health and racial equity lens. And with that is a deep commitment to be able to build a learning community. And so to that end, we are just, we're proud to be a sponsor for today and look forward to the ongoing conversation. So with that, Mary, I don't know if I turn it back to you or Vita, but I thank you for this opportunity to be your partner, and congratulations on the symposium, and thank you all for joining us today for this important conversation.
Thank you, Kai-Ying. I would like to turn it over to my colleague, Dr. Scarton.
Good morning, everybody. It's good to have you all here. I can't see your faces, but I can see the numbers, so I know you're attending. We are going to begin with a body scan meditation. You'll have to forgive my dog is feeling a little bit whiny this morning. So hopefully she engages in the meditation with us. But this will help us settle into this space from the different areas in which you're attending. I know we're all over probably here. So I just wanted to help us settle into the space and set an intention for this symposium. I think it goes without saying that please feel free to turn your camera off for this, or keep your camera on, close your eyes, maintain a soft gaze, whatever works for you. Okay, so begin by bringing your attention to your environment, slowly looking around and noting that you're safe in this moment. Bring your attention into your body. You can close your eyes if that's comfortable for you, or maintain a soft gaze. I encourage you not to focus on anything in particular if your eyes are partially closed. And you can notice your body seated wherever you're seated, feeling the support of the chair or the floor beneath you. Take a few deep, long breaths within the range of what is comfortable for you. And as you take a deep breath, bring in more oxygen, enlivening the body. And as you exhale, have a sense of relaxing more deeply. You can notice your feet on the floor. Notice the sensations of your feet touching the floor, the weight, the pressure, warmth, vibration. You can notice your legs against the chair, any heaviness or lightness that you may feel. Notice your back against the chair supporting you or suspended, the strength of your body holding you upright. Bring your attention into your stomach area. Notice if your stomach is tense or tight. And if it's tight, can you allow it to soften? Maybe take a breath to help you do so. Notice your hands. Are your hands tense or tight? See if you can allow them to soften. Notice your arms. Feel any sensation in your arms. Do your best to allow your shoulders to be soft. Notice your neck and throat and see if you can invite a sense of relaxation in there. Try to soften your jaw and do your best to allow your face and your facial muscles to relax. Next, notice your whole body and take one more big breath and feel that breath in your body. If you're not able to notice sensations in all areas of your body, that's okay. We're more connected to certain areas of the body more than others at different times of the day. So maybe take note of where you're feeling the most sensation or the most presence in your body at this time of the day. And note how that changes. So be aware of your whole body as best as you can and take another breath. Without focusing on anything in particular, slowly open up the eyes and allow your head and your neck to gently rotate, taking in the space that you're in. And when you feel ready, return to your normal gaze. And lastly, I would just ask that you be here in stillness for a few seconds and just take in your surroundings in order to enliven your body and get ready for the day. Note an intention for today's symposium. And sit for another few seconds focused on that intention. So we'll take one more breath in, and as you exhale, I invite you to join us back. Turn your video cameras on if you'd like. We'd love to see your faces. And enjoy the day.
Thank you so much, Dr. Scarton. That was really lovely, especially after having technical difficulties all morning. I needed a minute to recenter as well. So now I would like to introduce both Dr. Ryan Quist and Ian Evans to start us off as our opening panels.
All right, good morning. Come to you from Sacramento County, so Behavioral Health Director for Sacramento County, and I'm just going to talk a little bit about where we're at and then hand it off to Ian to do the same regarding Yolo County. So what I'd like to do is I'd like to do a little bit of a look back, a little bit of a status check on where we're at now, and a little bit of forecasting about where we might be in the future. So looking back here in Sacramento County, we implemented the Drug Medi-Cal Organized Delivery System on July 1st of 2019. What this did was it increased the variety and the different types of services that were available to our community. We added in case management, we added in intensive outpatient. We were able to expand residential treatment to include anyone with a substance use disorder challenge. So this was a really great initiative that we're very happy that the Department of Healthcare Services at the state of California brought to the state of California. It's been a really great initiative. As a part of that, there was funding that was invested from the state general funds. There was funding invested from our local Sacramento County general funds, and we're working on expanding the services that are available. So like I said, that was July 1st. And in the year since then, we've seen a 90% increase in the number of individuals that have received services. We've also seen the number of actual services being provided double. And so we're very excited about this additional capacity that's available to those in need of substance use disorder services in Sacramento County. We do anticipate that we're still in our growth phase, though. Looking at some of the counties that went first. So, for example, Riverside County, I think, was the first county that launched this great initiative. They are now into it. I was trying to remember this morning. I think maybe 5 or 6 years into it, and their amount of expansion is in the magnitude of a 600 to 700% increase in the amount of services before they had implemented. So we know we're still in a ramp up phase, and I'm very excited to be able to provide more services to the county. So that's our look back. Now let's sort of take a look at where we're at now. Right now, of course, we're in the middle of a pandemic and dealing with all of the challenges that go along with continuing to provide substance use disorder services. At the beginning of the pandemic, we very quickly got the message out there that behavioral health services are essential services, just like any other health services. And of course, our public health colleagues were extremely involved with dealing with the full, they were having to do everything that came in front of them. And so behavioral health got involved and began to help make sure that our providers had access to things like PPE, and they had access to technology in order to continue doing their work, make sure that we were able to convert all of our services from in-person services to telehealth and video and phone-based services. So that was quite the lift, and we're very appreciative and impressed by how resilient our providers were as they went through that conversion. Now here we are as we're starting to talk about vaccines. And of course, once again, we had the conversation that, again, behavioral health services are health services, and our providers also need access to vaccines. And we have part of the County Behavioral Health Directors Association. We had a representative, Dr. Ronnie Kelly from San Bernardino County, on the state's CVAC, Community Vaccine Advisory Committee. And so she has very sharp elbows and is constantly helping remember and remind that behavioral health services also need to be at the table, and our providers also need some of the same protections in order to do their important work. It was on New Year's Eve that we got the state to put out in writing that behavioral health should be prioritized along with other healthcare providers. And on New Year's Eve, our wonderful partners at Public Health were already providing plans to my team in order to get our behavioral health providers vaccinated and in line for vaccines. And so that's where we're currently at on our COVID response. One of the other things I'll mention in terms of where we're at right now, if at the beginning of the pandemic, I was having to, signal to everybody, my community, my county leadership, that we were anticipating as a result of the economic downturns, as a result of COVID, that we were anticipating that our funding for our substance use disorder services as well as mental health services was going to go down, because all of our funding sources are linked to economic things. So we get a lot of our funding from sales tax and vehicle license fees. And those were projected to be going down as a result of the economic challenges. Well, that was at the beginning of the pandemic. And now at this point, I have never been so happy to be wrong. We are seeing that our realignment funds, which are those sales tax, are coming in at levels that were not anticipated. Basically, because of all the supports, PPP, all the different things that we're doing in order to help our community members keep going. Sales did not go down. People continued to buy things. And so that's a good thing for funding as it relates to substance use disorder services. I don't think we're completely in the clear, but it's nowhere near the levels of cuts that we were concerned about at the time. So at this point, I know that our providers continue to do the important work. I think we've seen some workforce challenges around being able to stay at work sometimes because individuals are going out into the community, their family members are going out into the community, and there are lots of circumstances where family members have been exposed to COVID, or they themselves have been exposed to COVID or suspected to be exposed to COVID, that is impacting our ability to maintain the capacity. And of course, when we do residential treatment, those services have to remain in person. So for our in-person services, we continue to work on a day-to-day basis. Each day seems to be a different day in terms of who's going to be available to be a part of the workforce and be able to do the important work to support individuals in need. So that's where we are today, is we continue to work with our day-to-day challenges around COVID. Now, I was just going to briefly talk about things to come at the state level. A little bit of down in the weeds, but the way Medi-Cal works is the state of California's Medi-Cal benefit is defined in terms of what services are available to whom, is all defined by a waiver. And this waiver is basically an agreement between the feds at CMS, which is Centers for Medicaid and Medicare Services. This waiver defines how, what Medi-Cal services look like in the state. Well, our last waiver is up, it's over. And our next, and right before COVID, the state had begun doing the process of getting the new waiver written and started the process to have to get that approved by CMS. Well, COVID hit, so it got delayed for a year, but now we're still moving forward with that work. And basically this year, as a part of this waiver, we're seeing a significant amount of attention from DHCS, which we appreciate in terms of making some improvements to what the plans are for behavioral health Medi-Cal services in the state of California. And there's a lot of information in there. It's called CalAIM, California Advancing and Innovating Medi-Cal, which you can find by Googling CalAIM really easily at DHCS. So it's really extensive, and I'm not going to go into all of it, but it's exciting stuff. We are looking at ways we can make improvements to the behavioral health services, and to not try to go through every single one, but just to give you a couple examples. One of them is the proposal to do payment reform. Payment reform would basically take us out of the really antiquated current methodology by which we get reimbursed for services. It's really detailed, so I'm not going to try to do all the detail, but to try to do just a little bit of it would be that currently we're reimbursed based on something called a certified public expenditure, which means we have to spend $1 before we get our 50 cents back from the Fed's reimbursement, and that we're limited to actual costs. So we always have to demonstrate that we're always being reimbursed at exactly our cost, never more, never less. This is a challenge because that means we're never able to actually, begin to reinvest additional funds back into our system. If we make more money, then we actually have to settle back to to cost, and we're not able to reinvest those funds. And so the current proposal on the table is a reform which would allow us to hopefully begin to expand the resources that are available and draw down as much federal funds as we possibly can in order to make that happen. So that's one, is our payment reform. The second one, and this has, I'm going to try to make it specifically linked to substance use disorder services, is regarding documentation modernization. We have really antiquated methods for documenting what services we provide in substance use disorder services. Lots of signatures, lots of requirements around exactly what you have to document. And if you don't document that, you lose your money. Providers lose their money. I feel to some extent there's a lack of equity as it relates to other healthcare services. When I go to my doctor and I get a prescription, I don't have to sign a care plan or a treatment plan, and then I have to sign a consent for my medications and sign this and sign. It's just, it's so much more documentation that's required in behavioral health services, at least in the Medi-Cal arena. And so we're looking at making some changes to those documentation requirements. As one, I think, relatively big example is that in substance use disorder services, you can't begin to be reimbursed for services until you have an assessment completed, a diagnosis. You have to have a diagnosis. And we're looking at hopefully taking that requirement away, where you will be able to be reimbursed for services before you have a diagnosis. Because we all know when somebody comes into substance use disorder services, there's often some hesitancy with which they come, and we need an opportunity to engage with that individual, develop a relationship, develop rapport, and before they're willing to start, pouring out their souls as a part of the assessment process. And so this will give us an opportunity to take the time we need in order to engage with our consumers and be reimbursed for that important activity of engagement. So those were just a couple quick examples. As a part of the managed care plans, they are looking at something called in lieu of services. And for the substance use disorder continuum, they're looking at introducing sobering stations, which would be a new level of care, which we currently don't have within the state of California. So those are just a few examples that I'm looking forward to as a part of our soon implementation. Some of these might start being implemented as early as January 1st of 2022. Then in terms of a long-term plan as it relates to CalAIM, we're also looking at, in 5 years from now, an initiative that I'm particularly excited about, that we do a better job of integrating mental health and substance use disorder services. Where right now we have different requirements for substance use disorder services, different requirements for mental health services. If you're a consumer that needs both services, which many are, you have to basically, your provider, you have to double everything up. You double your provider, number of providers you have, you double the number of assessments you have to go through. For your providers, they have to double the amount of documentation they have to do. For the county, we have to double the number of contracts we have with the state. We have to double the number of requirements we have as it relates to oversight and accountability. And we should align these so that we only have one set of requirements for both mental health and substance use disorder services. And the state of California and DHCS have heard that message and are interested in supporting moving towards this direction. We're looking at probably a 5-year timeline for that, though. So that's a little bit of a longer term into the future timeline. So I think there's a lot going on. I think substance use disorder service delivery, we have a lot going on. Everything from dealing with our day-to-day pandemic, as well as beginning to plan for what's coming into the future. And I just want to take a moment and express my appreciation for all of you in terms of your focus and your energy and emphasis on the importance of SUD services. And you're taking time out of your very busy schedules to be here to focus on continuing to make improvements to the things that we're doing, continuing to find ways to do things better. So thank you very much. And I'm excited to see the rest of this agenda, and I'll turn it over to Ian.
Great, thanks, Ryan. I'm gonna, I was gonna share my screen. It says host is disabled. Dr. Rivas, is there, or others, is there a way to allow me to pull up a brief PowerPoint real quick?
1 second.
Carl is on it.
Great, thank you, Carl. While he's working on that too, I just want to highlight a couple of the important pieces that Dr. Quist shared from Sacramento County and share a little bit about the DMC ODS waiver in Yolo County. We started July 1st, 2018 here, and to Dr. Quist's point, we have seen a 261% increase in the amount of clients being able to be served through those expanded services that he shared. And so I think when we look at access to care and access to services, that's the first kind of measure of things that we want to see in terms of is a system improvement like that working? Are we allowing more folks to have access to these medically necessary services? And then, you know, we start to dig in year 2, year 3 as we're entering now into more system improvement stuff. What's going well, we, you know, obviously expanded a huge array of services. And so what's going well, and where are there some kind of pressure points or things we may need to figure out in the, you know, in the coming years. So some of that is what I'll touch on later on with our systems of care project here, and all the different pieces of the system integration tie into that we're doing here in Yolo in different ways. But I think the other important piece that Dr. Quist talked about is, you know, I'm grateful for this forum because it gives an opportunity to talk about something other than COVID, which I think is probably been the most talked about thing on everybody's agenda for the last, you know, 11, 12 months. But there are some pieces that I think we can learn and recognize that COVID has forced in positive directions. And so I think one of the things we've seen, and as Dr. Quist noted in Sacramento County, COVID has kind of forced some integration between primary care, public health, and the substance use system, looking at ways to do testing, to do screening, talking about and having conversations around how is it safe to bring folks into residential treatment during COVID, and what protocols and practices do we need to have in place? And if we have an outbreak, you know, in one of those facilities, who needs to be involved, and how can we quickly kind of isolate and contain that and get testing and public health contract tracing out there and those sort of pieces. So I think we've had, at least my thought, and I know we have a lot of folks from Yolo County on the call, so hopefully they feel the same. It can be a lot at any given moment, but I think it's also allowed us to learn different parts of the system, to make new connections that I think will be hugely beneficial moving forward as we continue to look at these things like CalAIM that Dr. Quist mentioned, and how we can better integrate our systems between primary care, mental health, and substance use. So I hadn't planned on talking about that piece, but I think it's hugely important as we're talking about integration. And so when Dr. Rivas and I kind of talked about this symposium and the purpose of it and looking at integration, and I wanted to highlight a few system level projects that we're working on, that we have worked on, and some upcoming ones that are either currently in development or just getting launched here, to give folks an idea of kind of some of the types of system integration you can look at, and how you can use data and other mapping processes to help inform that integration. And so I'm going to go ahead and see if this works here. Can everyone see is it just this normal slideshow now, or can you see?
Yeah.
This is excellent.
Still on PowerPoint.
It's still in the PowerPoint, not the cover slide?
Correct.
Okay. Let's see. Thank you all for bearing with me. Every meeting, of course, seems to be a little bit different. well, I'll just go through it this way for sake of time. So we have four kind of system level projects that we have worked on or continue to work on that for me really highlight the opportunity for integration. So the first is that I'll talk about is Stepping Up Initiative, and that's a nationwide initiative. If you want to learn more about it, the best place to go is stepuptogether.org. There's a ton of material on there. The next initiative, the next two are actually funded by the Mental Health Services Oversight and Accountability Commission. So it's a statewide commission that oversees all of the MHSA funding. And that MHSA funding is what some folks refer to as the millionaire's tax. So several years ago, California passed, I believe it was Prop 63, but I'm probably wrong on that prop. And it's been kind of dubbed the millionaire's tax. So essentially anybody making over $1 million has a percentage of their tax money go towards expanding services for the underserved and sometimes uninsured populations in the community to really enhance the type of services. It's typically been focused on, MHSA has typically been focused on prevention and early intervention and full service partnership services, which are really high intensity services for the mental health population. And slowly over time, there's been some allowances, and there was just an Assembly Bill 2265 passed that allows for MHSA dollars to help pay for some co-occurring services up until the point it's determined that the primary diagnosis is substance use, and then it has to transition to the substance use system of care to pay for. So the MHSOAC, Mental Health Services Oversight and Accountability Commission, is funding a couple statewide projects, Crisis Now and data-driven recovery projects. So I'll talk about those. And then there's been a ton of money the last couple of years, both from the federal government and from California around opioid response. And so we were recently chosen as one of 6 counties in California for a second round of this system of care project around improving substance use system of care. So wanted to highlight that for folks as well. So the Stepping Up Initiative, like I said, it's a national initiative. The website stepuptogether.org, and really what the initiative focuses on at the national level is kind of four key points. It is around reducing the overall number of severely mentally ill individuals in custody, reducing recidivism rates for the SMI population, reducing length of stay in custody. So for those that do end up in custody and reducing the length of stay for them, increasing treatment engagement, both while they have to remain in custody and then post-custody. Yolo County, in 2016, the board passed a resolution in support of becoming a Stepping Up County. And so we started work in 2017 to really get this work underway, and brought a huge amount of community partners from the criminal justice side, the mental health and substance use service side, NAMI, and local mental health board folks, and all kinds of first responders, the hospital systems, to map out what does it look like from what is Intercept 0, using what's called the sequential Intercept mapping, which is what you on the slide here, through Intercept 5, which is basically first contact with law enforcement or the criminal justice system through booking, arrest, court dates, and then release and reentry back into the community. So we decided to look at it from a behavioral health standpoint, not just mental health, not just severely mentally ill individuals, but if we were going to dedicate lots of time and resources to mapping this out, we wanted to take a look at it from a behavioral health standpoint. So we did an initial mapping process over about 9 months back in 2018 to do an initial map and gap analysis of what was working well, what wasn't. We revised it in 2019 and formalized a new version, this one in 2020. And And really from a system level, what this helped us do was identify pressure points in the system where we needed to fill gaps, and that would improve linkage and care for folks. Where were people falling through the cracks, and they were recidivating, they were re-entering the criminal justice system, and we just didn't have supports, either crisis and law enforcement involvement or post-release in the community. And so following this, we had a significant number of gaps identified. We needed funding for it. Our CAO and board and everybody were really pleased with it, really happy about it. And, Dr. Quist talked about some of the challenges around funding. And so they said, this is all great, go find funding for it. We don't have general fund, we don't have extra realignment dollars, et cetera, to kind of fill those gaps. So we formed a criminal justice grant committee, and in the first year, we're successful in 7 different grants to help fill some of those gaps. And some of those have already launched and have been in play for over a year now. Some of them are just getting off the ground right now. They are, one was to expand our mental health court program for SMI individuals that get involved in the criminal justice system to double the capacity. One was to divert folks from the state hospital who could be treated in the community. And then there were some around housing and residential substance use treatment, adding some detoxification, withdrawal management beds to the community. So I wanted to highlight this just because I think it's an example of a great federal initiative that focuses on a certain population. And locally here for us, it was an example of how we could take that framework and adjust it to what makes sense in Yolo, and not just focus on the SMI population, but focus on behavioral health. And this has really served as a planning document for some of our local committees. There's a criminal justice committee called the Community Corrections Partnership, who aligned the gaps identified with their strategic plan, their 5-year strategic plan. And so now they're working to tie the funding to those gaps long-term. So I think that's just one system piece of how this type of work can help look at integration, look at gaps, and identify funding, and then puts kind of some strategic efforts towards it moving forward. The next one I wanted to talk about is this Crisis Now initiative. So this is one that is the newest initiative that we've actually started on in Yolo. Again, it's NHSOAC funded, which means it's a direct state allocation that gets paid to counties participating. There's, I believe, 8 counties, Yolo and in the surrounding 8 counties that are participating in the Crisis Now initiative. It's an 8.5-month learning collaborative that's really designed to, like it says there, optimize behavioral health crisis and response. And those are the 4 core elements that they focus on. So the great part for me around this is I grew up in the substance use world, so to speak. I've been working in substance use for about 12.5 years now. And one of the things when I started my career was, if we had folks were still kind of looked at in this siloed treatment aspect of, you treat mental health over here, you treat substance use over here. There was still some thinking, and I think it's still out there in some communities, that, well, we have to stabilize their mental health first before we can get them into substance use treatment, or vice versa, depending on who you might be talking to, your audience. And that's not only challenging as a provider trying to, help that client that's in front of you right there, but it's also incredibly challenging for a client to try to navigate those systems. And just the sheer fact of anyone who's had to try to sign up for Medi-Cal, it's a cumbersome process. And so if you're struggling to not use substances, and you may have a co-occurring mental health issue that's currently untreated, we're asking clients to do things that are near impossible in that type of system. So the Crisis Now initiative, in those 4 core elements of it, looks at crisis as a behavioral health crisis. It doesn't differentiate substance use or mental health crisis. And so when it talks about standing up things like a drop-in or kind of crisis receiving center, it's more in line with like what Dr. Quist was talking about with CalAIM for these sobering centers, where it's law enforcement shows up, they drop somebody off, the staffs, may ask a few intake questions, but the answer at the door is, yes, please, we'll take another, bring us as many clients as you can, we'll serve them, we'll get them stabilized, we'll move them on, to the next level of care after we mitigate this crisis. And it really pushes the continuum to be developed around crisis, to have a 24/7 true crisis response line that can handle and dispatch 24/7 mobile crisis response teams. And their model, the Crisis Now model, in terms of efficacy, pushes a co-responder model that is a peer and a clinician rather than a clinician and a law enforcement officer as the first kind of line of defense, so to speak. And so I think we're seeing in, different parts of the country, and we've seen a lot of it in 2020 around this, kind of defund the police movement. And I think what folks are targeting now is efforts like this. We need law enforcement partners. We need them engaged in this. We can't do it alone. And there are absolutely appropriate times where we need law enforcement to ensure safety. But on the flip side, we also need to have a system where we can have a peer and a clinician go out and be that first kind of contact, and where there isn't a safety issue. And so that's one of the great pieces of the model that they continue to talk about, and have conversations with local law enforcement agencies and the community around building this type of model. I think they also really look at, if you build out an effective continuum, cost is always something for counties and jurisdictions to think about with this type of stuff. And so if you think about, we need to add additional pieces to this puzzle, everyone's inclination is always, we need to go find more funding. And their model is, you don't necessarily need to find more funding if you can reallocate funding to some of these other pieces of the system and mitigate hospital costs, mitigate, jail stays. There's money that you can reinvest in the system for these mobile response teams that help for these drop-in centers. And so there's ways that you can, shift funding around. So as a quick snapshot, a little bit of what we're doing in Yolo around that. It started a couple months ago. And so over the next 6 months, our plan is to really continue learning from them, continue to work with our partners and our local counties that are also part of it to see where we can do regional partnerships and how we can really build this out. For those of you that are familiar with the Forensic Mental Health Association of California, they have what's called a Words to Deeds track that focuses on stuff like this. And so they actually have a March session. I think it's an 1.5-hour webinar that's specifically focused on Crisis Now. And there's going to be lots more discussion than I have time to share this morning. So the next piece I'll touch on real quick is what's called the Data-Driven Recovery Project. So Yolo County as a whole, and our agency, Health and Human Services as an agency, really has dedicated itself over the last couple of years to trying to push to become more of a data-driven decision-making entity, county and agency. And so wherever we can, we want to try to link in data to affect our decision-making. So one of the things we noticed when we went through the Stepping Up initiative on the first kind of go around was we would identify gaps and say, we need better reentry for folks. We don't have enough people that are receiving folks when they release from custody to actually effectively kind of case manage them, pick them up. They also, leave at all hours of the day and night. And so we need more reentry. And so that was one of our priority gaps, but we don't know, we didn't know whether we needed reentry for 50 people every single month or 200 people every single month. And that's obviously a much different kind of staffing need. And so we took advantage of this funding from the MHSOAC It's again a state-funded project. Yolo is the lead county on this, and it's a 10-county project across 2 different cohorts. So cohort 1 is set to wrap up at the end of this year, and then cohort 2 continues all the way through next year. You can see, some of the high-level summary pieces around the project there, but one of the, the overall work being done is to look at both criminal justice data, so looking at jail booking data, but also looking at our in-custody mental health, behavioral health provider data, looking at court and district attorney information, looking at our treatment records, so mental health and substance use records that we have in our county EHR. And then one of the pieces that Yolo has done and a couple other counties are starting to do as well as part of this is on the homeless side, there's what's called the Homeless Management Information System, which is essentially an electronic health record for the homeless system that contains a ton of information around where folks go in terms of emergency shelter, transitional housing, how many exited permanent housing, et cetera. And so there's a consultant that's leading this data project. I'm not a data person. I don't understand the back-end algorithms and how to do all this. But what I do understand is when he puts it all together and says, 50% of our population that recidivates was served in emergency shelter in 2019. So what that tells me and what we're starting to have conversations with our homeless system about is, how can we link what we knew we needed in terms of better reentry with some more housing continuum on the outside? Because if they're going into emergency shelter, there might not be wraparound care for them that's allowing them to stabilize and set up with some of these mental health and substance use services. They make housing applications to get them into permanent housing. And if they're worried about where they're going to sleep the next night and where their meal is, they're going to forget about the court date that they were supposed to go to. They're going to forget about, checking into probation in 48 hours. And so they may get a violation and get put back into custody as a result. So that's the type of tangible data we're starting to get now as a county that we can start to plug into those gaps that were identified and see what really we know this is a pressure point. What's the volume of pressure point, or need that we have in the community? And the other component that we got approval for locally here is to have a trauma piece of this. And so we're doing a study. A portion of this is to do a study on those involved in the criminal justice system that have behavioral health issues, to really understand the effects of toxic stress on individuals with behavioral health conditions who end up in the criminal justice system. And so the information that's being gathered is we're working with some of our partners and providers on doing ACEs, adverse childhood experiences screenings. And for those that have a score of 4 or higher on that in the adult population, they will also get a cognitive assessment to help better understand what some ongoing treatment needs might be. And we have a control group that took the same screening. And so we have a researcher that's going to be putting together kind of a white paper around research and what we could learn and how that could inform treatment moving forward around that area. And so the last project I wanted to just touch on briefly is the newest project here in Yolo. We haven't officially launched it yet, but I'm incredibly excited about it. Like I said, I kind of grew up, so to speak, in the substance use world, and the federal government from SAMHSA through kind of passing money to Department of Healthcare Services, who then contracted with a technical assistance group called Health Management Associates, or HMA, is doing a lot of work statewide around criminal justice, substance use, behavioral health integration, and really looking at how we can improve systems of care. And so the newest project is this Systems of Care project. This is kind of what the project will do and the different components. But really the exciting piece for me, again, is this looks more broad. So it doesn't look at just our contracted substance use providers that we have as a county. It says, let's look at the entire ecosystem of substance use So let's bring in the hospital partners. Let's bring in the criminal justice partners. Let's bring in, our opioid coalition that we have here. Let's bring in social services. Let's bring in, child, youth, and family services. These different parts of the system to all bring them together. It's a 24-month technical assistance project, but I think it was really brilliant in the way they designed this. They have an initial, what they call a performance or a process improvement event, where all those partners get in the room and say, okay, we're embarking on this 24-month, ecosystem development process to look at the entire system of care, where we can increase medication-assisted treatment availability and funding, where we can look at transitions between levels of care and warm handoffs, where we may need to add staffing, where we have too much and need to flex, and what parts of the system can help inform that. There's those large kind of process improvement events that are going to happen. The initial one is happening in April, and then there will be future ones. I believe quarterly is kind of how they're setting it up. But they have multiple coaches that are available as part of the project, so that any provider that's part of our substance use ecosystem that has specific questions around how they as a provider can improve their care, look at co-occurring services better, look at how they intake clients and transition them to lower levels of care, can have specific technical assistance as a provider. And so you don't on a monthly basis, you don't have to get 50 people in a room that have lots of schedules and it's hard to navigate. You can have these larger level events, and then for the next 3 months, everybody kind of goes and does their work and brings it back to the system, and we talk about okay, what did we learn? Where can we move resources? Where can we improve for the next kind of step in the process, and really set these SMART goals that we track over time. And I'm really excited about it because, like I said, we are now 2.5 years into our drug Medi-Cal organized delivery system waiver. We just had 2 of our hospitals get what's called a ED bridge program, which means that they can fund staff in the hospital to get clients started on medication assisted treatment while they're in there, and have a position that links to the greater continuum of substance use care out in the community. And we have some other criminal justice grants, like I said, that are getting off the ground right now that serve the population. And so I think between all these initiatives that I highlighted here, our hope as a county is that they all kind of interplay with each other and help us start to get a better picture of what it looks like overall as a behavioral health system, and where we can make improvements. So I know that was a lot. I think we have time for some questions and stuff, hopefully. So I'm going to stop.
So first of all, thank you so much, Ian, Dr. Quist. This was lovely. This is brilliant. Thank you so much for going through that. So right now, any questions, I'm going to manage the chat, and you're welcome to raise your hand. You're welcome to, and Carl, I'm not sure if in webinar format we're able to, if they're able to raise their hand and speak up, but any questions? One of the questions in the chat was, could you mention the legislation again? And this was kind of at the start.
I talked about a couple different ones, but I think Assembly Bill 2265 is probably the one that folks were curious about. It just recently passed sometime last year. I don't remember, my COVID timetable is all thrown off. What I think was a week ago is actually a year ago. And so I know it passed sometime before, last week, and it allows for, like I said, it allows for MHSA funding to be used for co-occurring assessment treatment until the point that somebody is determined to have a primary substance use diagnosis, and then they need to be paid for by other funding than MHSA dollars.
One more question. That was the only question. Any other questions? And please don't hesitate to open up the chat box and throw any questions in there.
It's better if you use the question and answer box.
Oh, I see what you're saying. There we go. Okay, we'll give everyone just a few seconds to see if they have any other questions they want to add in there in the Q&A box at the bottom, but right now we have none. So I cannot thank the two of you enough for starting us off with such good, rich information about the direction that you're heading in terms of the counties, and gives us good information to kind of stitch together throughout the day. So what we're gonna see throughout the options today, and just to give everyone to confirm that our goal is to record everything and make it available so that you can view some of the things you may have missed along the way. We have, I'm going to throw into the chat the location of the agenda, because each of the breakouts are going to have a Zoom link. And in that agenda, it should have it embedded. If you have any questions, please, or have any issues, go ahead and email me. So what's gonna look like for the rest of the day is we're gonna have a brief break, and then beginning at 10:30, we'll have 3 breakout options. Then there'll be a quick like lunch, so you can take a minute, grab a snack, and then we'll have a listening lunch so that you can eat and listen to the speaker at lunch, which will be in this webinar link. And then we will have some afternoon sessions with those links in the afternoon. So one question from Joe: is law enforcement hesitant to work with the mental health workers, or are they eager to participate in this partnership?
Do you want me to start, Ryan, and then you can maybe talk from the Sacramento perspective? Okay.
Yeah.
I think I often heard when I first came to the county from like state reviewers and stuff that if you've been to one county, then you've been to one county. And I think that's because every county is different and the partnerships are different there. So I would say in Yolo, our law enforcement for the most part in pretty much every jurisdiction is eager to partner on this. They want help, they want resources, they want support around they're not trained clinicians, so they don't know when they go out and they either receive a crisis call or they receive a call around a homeless encampment. They don't know if it's a mental health issue or a substance use issue or something that they're seeing there. What they know is the community called them because of some concern, they responded, and they need to act based on that call and response. And they can kind of act in one of several ways. They either go out and have conversation and determine nothing's there and they leave, but they recognize that doesn't help solve the problem long term because it wasn't a law enforcement issue. So they didn't arrest the person, they didn't cite the person, whatever, but they also know that person then didn't get connected to any ongoing services. They could cite the person and not arrest them and hope that they appear in court, and then they may or may not, and all of a sudden now they have additional missed court appointments, and it just adds on to the layer of things that have to get solved before somebody can move indoors and receive services, or they can arrest somebody or 5150 them, right, and take them to the hospital. So I think they're willing and eager. I think one thing that I have learned in my time here and would advise folks in other communities, relationships and partnerships are key, and they go both ways. And so whenever you're doing some large thing like a crisis now, where you're talking about shifting the way that we respond to crisis calls, you really need to do some pre-work with those partners before you get on TA calls and before you start this initiative and everything. Reach out and say, hey, we want to do this as a county. This sounds really exciting. It works much more effectively if you all are on board and participating. So there's weekly or every other week county to county technical assistance webinars that the folks facilitating Crisis Now hold. And we often have 5, 10, 15 representatives from our local law enforcement agencies that attend those, because they want to learn the information and see how it's going to affect them and their workflow. So I think that's the YOLO piece, I'd say.
I can't emphasize enough what Ian said around the importance of the relationships. In terms of where things are at in Sacramento County, I'm pulling up my notes. So it's about a year ago, I think. No, it would have been more than that, because that's how long COVID's been here. You're right, Ian, time's all messed up. So maybe a little bit more than a year ago, we increased a number of our mobile crisis support teams from 6 teams up to 11 teams in terms of our funding. So we have funded teams. They are more difficult than some of our other services in terms of recruitment, because it takes a special kind of clinician that is interested in working directly with law enforcement. Our model is the ride-along model, where the clinician goes out with the law enforcement officer. Currently, we have, to give you a flavor of the range of different law enforcement agencies that we work with. Currently, we have 2 with our sheriff's department in the North Division. We have 1 in the South Division for sheriffs. We have 1 with Citrus Heights Police Department, 1 with Rancho Cordova starting on March 8th. We have 1 with Folsom Police Department, Elk Grove Police Department, and then we still have other law enforcement agencies that are still interested in waiting on us to be able to recruit and hire those ones in Galt Police Department, Sheriff's North Division would like another one. So you sort of get a feel that a lot of our law enforcement agencies, they've seen how this looks and seen the benefits of doing this. And so we continue to have requests for more of these teams. With the city of Sacramento, we have a unique relationship where we have a different model. And this is a follow-up response where once they're putting together an Office of Community Response, and we're working very closely with them on that. When folks in the Sacramento Police Department, when dispatch identifies a mental health related or behavioral health related need, they will have an initial response from the Office of Community Response. And then if appropriate, they make a referral over to the county's community support team, which will then follow up with those individuals within 24 to 48 hours. It's a really great model. We've already seen some outcomes that demonstrate that there's a reduction in the number of repeat calls for those who have been supported by our community support team. So a little bit of a flavor of the different things that are going on. I can't emphasize enough the importance of the relationships, and in those relationships that we come to, shared goals and shared understanding of, how we're going to approach this together. That's what it looks like in Sacramento.
So and I think sorry, Dr. Rivas.
No, I apologize. Go ahead.
The only other piece that I would add too is it's not just around mental health and substance use, but it's also around homelessness. And each of our jurisdictions locally here within their police department, they have a homeless coordinator embedded there, and so they go out with dedicated law enforcement folks to do outreach. And I know we have a wide kind of range of folks that are on the call here or on this, webinar and attending. So for those folks that, were aware of the Project Home Key that the state released, it was a purchase and renovation of properties to acquire for longer term housing support needs. And it was a huge initiative pushed as COVID response through the governor's office. He has asked the legislature for a second round of that funding, $750 million statewide, and $250 million to be allocated during this current fiscal year. But what that does is it allows jurisdictions to purchase and renovate either motels or hotels or existing kind of buildings and repurpose them for longer term housing. And I bring it up here because we had the city of West Sacramento applied for applications for that. They were successful in 3 and actually moved forward in 1 just because of the total cost of it. But the planning folks in the city of West Sac really relied on their homeless coordinator that's embedded within their law enforcement to help inform setting up that structure. And he's the link between, ensuring that that the law enforcement folks kind of understand the unique population around homelessness, and ensuring that the homeless folks understand the unique needs and direction of law enforcement, and that he brings it to the city as well, so they're aware in these projects. Because, from an outside perspective, you can think, oh, well, it's a housing, so we need our housing providers there, we need the county and city involved and that sort of thing. But anytime you stand up a new, like 40 unit complex, if it's for folks that are coming, directly, housing first basically means get folks off the street and get them into housing as soon as possible with limited barriers. If you put 40 folks in a housing kind of first model like that, the likelihood of increased calls for that area is probably pretty high. And so having law enforcement understand and be at the table from the beginning helps them understand, what are we doing? What's the goal? Like Dr. Quist said, what's the goal? What's our common outcome? What do we want to work towards here? So that they can help mitigate and communicate to the community that we have another project in one of our other jurisdictions that's been a little controversial for a while. And the community has shared that, there has been lots of concerns around substance use and mental health issues, and the chief of police in that jurisdiction actually went to a city council meeting recently and said, none of that, we understand the concerns, but none of that bears out from a law enforcement perspective. We don't see high rates of calls over there. We're not seeing lots of mental health or substance use issues over there. And to have a partner that's willing to go forward and make that comment from a statement of law enforcement, I think helps also put the community at ease and helps us level set overall to hopefully we can address some of those kind of stigma, we're talking about stigma here, right? So some of those stigma kind of NIMBY issues that pop up when we're talking about these things. So I'll stop there.
No, that's wonderful. I was wondering if there are any steps that individuals in this webinar could take to get involved. And Project Home Key, it looks like one avenue. Can you think, as we're wrapping up, of any other words you have for the group in terms of how they could maybe get involved and expanding this either in their counties or just in the services that they're providing right now?
I'll go short and be super brief because I think I've talked a lot already this morning, but I think we have 108 people still on. We had 121, I think, at one point. Two pieces. One, kind of be the voice that helps reduce stigma, be the one that helps share informed information about housing and mental health and substance use and what it truly is and what the reality is around that. And two, to the partner piece around criminal justice and any other partner you're working with, be open and understanding to their perspective. Because I think, from the social justice kind of stigma reducing behavioral health side, we can often get so caught up in the emotional aspect of it and wanting so bad for this care for our clients that we can come at it from, kind of a more forceful, very direct piece and advocation side of it. And if we're not open to the other perspective, then that's going to stop the relationship in the tracks. And that makes it, 2, 3, 4 times as difficult to get any of those actual progress pieces done that we all want to see happen.
I just say amen to that, and as well as add, at this time more than any other, it's really important for us all to be looking out for ourselves, for our families, for our friends, continuing to make sure that we're checking in with each other. We have the power to continue to support those within our lives, and this is the time more than ever that those individuals that are the important people in our lives need our support.
Thank you so much. Thank you so much for being here and sharing so much of this rich information. So we appreciate it very much. I think at this point we are nearly at 10:30. So anyone still on the call, again, the agenda you can find with links for the day, and I have it in the chat. Email me if you have any problems, but you'll find 3 sessions available to you, and we'll just keep these conversations going. Dr. Quist, Ian, thank you so very much for your time this morning.